Good afternoon. Today our lecture is gastric cancer. Features. Most gastric cancer patients present with advanced disease. Early gastric cancers account for only 5 to 20% from all gastric cancers. Even patients who present in the most favorable condition and who undergo curative surgical resection often die of recurrent disease. If you remember the anatomy of the stomach, there are 3 parts. Cardia part, Padi and pylorus. It is important to know, or when we write diagnosis cancer of stomach, to know the localization of the cancer, in which part of stomach. Because operation or operative type of treatment depending on localization of the tumor, depending on which part of stomach. The stomach wall is made up of 5 layers: mucosa, submucosa, muscular layer, subserosal layer, and serosal layer. The same very important in treatment of patient with gastric cancer, to know the histological type of cancer and to which layer invasive. The first, to know localization of the cancer, in which part. Next, type of histological type of cancer, and to which layer invasive. The peritoneum of the greater sac covers the anterior surface of the stomach. The vascular supply is derived from celiac artery branches. Left gastric artery, common hepatic artery, and spleen artery. If you remember, we explained that in oncology we must do, as standard in all operation, we must do lymph dissection. And here I must do lymph dissection depending on the localization of the tumor. Lymph dissection of lymph nodes through the left gastric artery, common hepatic artery, and spleen artery. The lymphatic drainage of the stomach is complex, as the same as the blood supply. And you understand here, all this group lymph nodes, we must remove it in as standard in stomach cancer. The same depending on localization. The localization of the tumor. Here is left gastric artery, lower esophagus artery, common hepatic artery, right gastric artery, gastric pleura dextra here, and spleen artery. Here is previous from spleen to fundus part of stomach. Epidemiology. Incidence. Highest rate is noted in Japan, 85% per 100,000 population. In Korea, China, and Taiwan have very high rates, 32.3 to 39.9 per 100,000 population. Lowest incidence, less than 3.57 cases per 100,000 population is noted in North America, Western Europe, and Australia. Large changes since 73 involve the decline in stomach cancer incidence rate. Yes, we see that increased year by year. Generally, in all cases or all cancer cases in all the world, the gastric cancer is the second most common case of cancer-related death in the world. The highest death rates are noted in Costa Rica, behind 67%, and in Japan, 54.6 to 55% from 100,000 population. And here is important factor. In Japan, maybe more cases than Costa Rica, but the death rate in Costa Rica more highest than Japan. Why? Because in the Japan there are screening program where they detect the gastric cancer in very early stages. And as you know, in early stages, the survival rate more better than any stages. In other words, in first stage or cancer in situ, more better prognosis, I mean survival rate, than second stage or third stage or the last stage. The lowest death rates are noted in USA 7.4, in Cuba 10.5%, and in Kuwait the same 10.6% per 100,000 population. Race. The rates of gastric cancer are higher in Asian countries than in the United States. Six, gastric cancer afflicts slightly more men than women. The male to female ratio for gastric cancer is 3 to 2. Age, the median age at diagnosis is 55 years. Range 40 to 70 years. The gastric cancer that occur in younger patients may represent more aggressive variant. It is usually the cancer occur in younger patients in all cases, or most common of cases, usually is very aggressive variant. Causes. There are three main groups of factors predisposing for incidence of gastric cancer. The first is alimentary diet factor. Familial or hereditary factors. Geographical factors, including climate, contents of microelements in the water and in the ground. And this is the first causes why the gastric cancer is very high incidence in Japan, because the elementary factor, the first, and second is geographical factor. Geographical factor, because the soils is deficiency of microelements. Other factors for gastric cancer: Helicobacter pylori infection, previous gastric surgery, and precancerous disease. Previous gastric surgery, it means before, the patient maybe in Diego gastric surgery through the ulcer maybe, or other precancerous disease. Precancerous disease include all benign tumors in the stomach, like polypus of stomach, leiomyoma, gastritis, pathophysiology. There are two conditions for the development of gastric cancer. The first is influence of carcinogens on the gastric mucous membrane. Presence of proliferation processes with metaplasia and dysplasia. Begin from gastritis to metaplasia under exposed many factors, and the last is dysplasia, and the same under exposure of many factors, as we told, from dysplasia become to be cancer. Histologic findings. The adenocarcinoma of stomach, 90 to 95% of all gastric malignancies. The second most common gastric malignancies are lymphomas. Leiomyosarcomas, 2%, and carcinoids, 1% and less, are the remaining tumor histologic types. As we told, the treatment of gastric cancer depending on localization, as we told, histological findings, because if we put diagnosis lymphoma, for example, of gastric, this patient don't need to surgery. They need to chemotherapy. Or if there are leiomyoma as precancerous disease, we can just remove this part or resection of this part of this tumor, I mean. And it's very important to know the histological types before any treatment. The localization of the tumor. Next, your step after diagnostics. Now we will discuss the types of diagnostics. To know the histological types. Macroscopic forms of gastric cancers. Exhibiting cancer, polypose, fungus, cancer, canthal, like this, polypose type or fungus type of cancer, Brazis borders, slow growth, may spread to 6 centimeters from the visible tumor. I mean from 2 6 centimeters from the visible. As here we see, for example, the tumor localization is in pyloric part, and here we understand that 6 centimeters may be spread to body of the stomach. Next form is endophytic form. Endophytic form. Here we can see it. Endophytic form. Or we call diffuse infiltrative and ulcer infiltrative cancer. Here, unlike exhibitive form, is rapidly growth without braces borders. Without braces borders. Here we see the tumor, maybe invasive submucosa or subserosa, without borders, braces borders. Malignant cells spread to 10 to 12 centimeters from the visible tumor border. Note, for example, here's tumor, maybe invasive. From pyloric, for example, from pyloric, maybe invasive to cardia of the stomach. Mixed form is exophytic component with infiltrative growth. The same you can talk about if we told about prognosis, depending the localization of the tumor, histological type of the tumor, form of the tumor, because infiltrative more aggressive type than exophytic form. For example, mixed form more aggressive, the same, depending on the same depending on the form of the cancer. There are 5 types of the tumor. Type 1 tumors are polypoid or fungitation. clearly demarcated, may be ulcerated, have late metastasis, have relatively good prognosis. Macroscopically, there are exophytous form. Type 2, tumors are ulcerating lesions. Ulcer cancers surrounded by elevated borders, sharply defined margins, difficult to differentiate from benign ulcer on gross examination, requires biopsy, have a relatively good prognosis too. Type 3, excuse me. Type 3, tumors have ulceration with invasion of the gastric wall. Lacks clear-cut margins, extensive submucosal infiltration, extends to the serosa, the same as I explained for you that it is important which layer invasive the tumor, extended to the serosa. These tumors are most common type of gastric cancer with relatively poor prognosis. Type 4 are diffusely infiltrating, more likely lineates plastica, leather, Potter stomach. This type have early metastasis with poorest prognosis of all gastric cancer. And the last type, 5 type, is cannot be classified. Side. 40% of cancers develop in the pylorus. 40% in the middle part of stomach body, 15% in the upper part, cardia, 10% involve more than one part of the organ. For example, from involve more than one part, cardia and body, pyloric and body of the stomach, more than one part. Spread patterns. Cancer of the stomach can spread by 1. Directly via lymphatics, via blood cells, blood vessels, hematogenously. Yes. Directly, lymphogenously, hematogenously. The staging and 10M classification for gastric cancer. T, as you know, tumor, N, lymph nodes, and M, distant metastasis. T1, the tumor invasive mucosa or submucosal layer. T2, muscular, the tumor invasive to muscular or subserosal layer. T3, if the tumor invasive to serosal layer. And the last is T4, when the tumor involve another organs. When the tumor invasive through the serosa to other organs, nearby organs, likely left lobe of liver, transversus part of colon, spleen, big omentum, retropancreas, or duodenum. In lymph node metastasis, in one, if the histological investigation find from 1 to 6 lymph node metastasis, it means in 1. In 2, lymph node metastasis from 7 to 15, and the in 3 is more than 15 lymph node metastasis after histological investigation. M metastasis, and it means distant metastasis. The most common, the first group or the first organs from the stomach is, if there are distant metastasis, is liver and lung. Staging or stage grouping depending on the NM classification, and the same survival rate depending on the stage, as you understand. The stage 1 divided to two groups, A and B. Stage 1A, it means T1 in 0 in 0. That the T1, as you understand, the mucosa or submucosa. The survival rate 88%, 5-year survival rate. 1P, it means T1 in 1M0. Yes, it means that there are in one mucous layer, and there are from 1 to 6 lymph node metastases. Or T2 N0M0. It means invasive to muscular or subserosal layer. N0. The survival rate 75%. The second group, including T1, N2, M0. T1, the submucosal layer. N2, lymph node metastasis from 7 to 15. Distant metastasis is 0. Or T2, the tumor invasive to muscular or subserosal layer. In 1 lymph node metastasis from 1 to 6 lymph node metastasis. Or T3, when the tumor invasive to serosal layer. And this survival, 5 survival years, 65%. Third group, third stage, I mean, divided to two groups, stage 3A and stage 3B. Stage 3A is T2 N2 M0. T3 in 1 M0 or T4 in 0 M0. T4 means invasive to other organs, as just now we explained, or transversus part of colon, or liver, or pancreas, or spleen, or maybe to diaphragm. T4. The survival rate is 35%. 3B, T3 in 2 M0, T4 in 1 M0, and the survival rate 10%, not more. Unfortunately, because the prognosis of 3B is very poor. And the stage 4, T1 to T3 in 3 more than 15 lymph node metastasis, and M0. T4 in 2 N3 or N3 M0, or any T, any in M1, stage 4. The survival rate will be 5%, not more. unfortunately. Early cancer symptoms. Early symptoms termed as small signs of gastric cancer syndrome. The first is weakness, diminished ability to walk, unpleasant sensation and heaviness in the stomach, physical depression with no apparent cause, loss of pleasure from food, change taste of food, and aversion for some kind of food. Advanced cancer symptoms. Indigestion. No, this advanced symptoms is depending on localization of the tumor. Indigestion, nausea or vomiting, dysphagia, postprandial fullness, loss of appetite, and weight loss. Vomiting, for example, if the tumor in pyloric parts or cardiac part, and the patient had stenosis. Dysphagia, the same in cardiac part. In carcinoma of the pylorus, sense of fullness in the stomach, vomiting the food taken the day before, musty smelling, regurgitation. In the cardiac cancer, a sensation that solid food sticks in the gullet. On stomach body cancer, hypochromic anemia. Physical examination. There are 4 the most common distant metastases of gastric cancer. The first, Verfax metastasis. On left supraclavicular area. Schnitzler's metastasis on peritoneum pouch of Douglas. Sister Mary Joseph metastasis in umbilicus. And the last distant metastasis is Krukenberg metastasis on ovary in womb. The complications of gastric cancer. The most dangerous complication is bleeding from the ulcerative form of gastric cancer. Acute bleeding. Late complications. Pathological peritoneal and pleural effusions. Obstruction of the gastric outlet, gastroesophageal junction, or small bowel. It's gastroesophageal junction or pyloric part. Bleeding from the esophageal varices. Jaundice, it means here is mechanical jaundice or metastasis in liver or extra hepatic metastasis, but blocked the bile from the blocked the bile. Inhalation from starvation or cachexia of tumor origin. Differential diagnosis. Benign neoplasms. Gastric ulcer. Because peptic ulcers and gastritis cause similar findings. Diagnosis often delayed. Jaundice and hepatomegaly, hepatic metastasis. Pelvic masses, Krukenberg tumors. Diagnosis. The patients with suspected gastric carcinoma, it is necessary to begin the evaluation with history taking and physical examination, palpation of abdomen, navel region, left supraclavicular region, Wehrhaf's metastasis. It means rectal and vaginal investigation, Schnitzler's or Krukenberg metastasis. The next step of examination are X-ray and esophageal gastroduodenoscopy. X-ray. Early gastric cancers. Type 1, as we told about types. Type 1 will be as lesions are elevated and protrude more than 5 millimeters into the lumen. Type 2, tumors are superficial lesions that are elevated, flat, or depressed. No, elevated as stage 2A, flat as stage 2B, and depressed stage 3. Type 3, early gastric cancers are shallow, irregular ulcers surrounded by nodular, clotted mucosal folds. Abnormalities in the gastric contour or as soft tissue masses indenting the gastric contour. On barium studies, gastroscopy told with barium. Advanced gastric carcinomas may be polypoidal, ulcerative, infiltrating lesions. Polypoid carcinomas are lobulated masses that protrude into the lumen. Seen in profile, these lesions are intraluminal, whereas benign ulcers project beyond the contour of the stomach, ulcerative form. Infiltrating carcinomas results in irregular narrowing of the stomach with nodularity or speculation of the mucosa. Carcinoma of the cardia are often missed during single contrast examination. Esophageal gastroduodenoscopy. Endoscopy has become the diagnostic procedure of choice for patients with suspected gastric carcinoma. Biopsy. biopsy samples obtained during endoscopy enable histologic diagnosis. And biopsy specimens can be obtained by patient forceps and taking small mucosal samples for histology studies. Because usually when we take biopsy, as minimum 3 biceps, and more better if we take 5 biceps. From 3 to 5 bases if there are no contraindication for biopsy, likely bleeding. Multiple biopsy specimens are needed to avoid sampling errors. CT scan of abdomen is primarily used to preoperatively assess patients with gastric carcinoma. As you understand, this CT scan of abdominal and thoracic cavity and lower cavity, it is as standard to exclude or include if there are distant metastases. CT scan is to assess the presence and extent of extragastric spread. This information is vital in deciding between palliative surgery and curative radical surgery. Loose CT scan is used to lymph node status and distant metastasis status, and also to monitor the response to treatment. CT scan methods of investigation. We see lymph nodes metastasis. Staging, intraperitoneal and omental metastasis consist of notice localized fluid collections and irregular thickening and straining of the mesentery and omentum. Transabdominal ultrasound of the stomach. The primary role of transabdominal ultrasound is to detect liver metastasis. Endoscopic ultrasound. This study allows for more precise preoperative assessment of the tumor stage. PET, positron emission tomography, depicts the primary tumor, but involved perigastric lymph nodes are not identified separately from the primary tumor. Chest radiograph or chest CT scan. This is done to evaluate for metastatic lesions. Laboratory studies. Complete blood cell count can identify anemia, which may be caused by bleeding. Liver dysfunction or poor nutrition. Electrolyte panels and liver function tests also are essential to better characterize the patient's clinical state. Treatment. Surgical care. There is one most common principle in surgical care of gastric cancer. Small tumor is need perform extensive operation. Type of surgery. In endogenous gastric cancer, total gastrectomy. Or gastrectomy with lower part of esophagus if the tumor from the cardia invasive to lower part of esophagus or gastroesophageal junction. Total gastrectomy presents at the edge of resected specimen, esophageal and intestinal epithelium are the criteria of readiness of gastrectomy. The margin on gastrectomy. It is performed subtotal resection for tumors of distal stomach and in exogenous gastric cancer. The criteria of the type of operation, gastrectomy or subtotal resection are localization of the tumor, microscopic form of the tumor growth. Now here we see in pyloric part, as minimum 5-6 centimeters from the border of the tumor, we can do subtotal resection of the stomach. Surgical care. During the operation, it is necessary to perform subtotal resection of stomach or gastrectomy beyond the bounds of microscopic borders of tumor to remove and block regional lymph nodes, lymph node dissection, removed laser omentum during gastrectomy in case of endophytic. Complication after surgery. Early post-operative complications, anastomotic failure, bleeding, alias, transit failure at the anastomosis, cholecystitis, pancreatitis, pulmonary infections, and thromboembolism. Late mechanical physiological complications, Denning syndrome, vitamin B12 deficiency, reflux esophagitis, and bone disorders, especially osteoporosis. Adjuvant therapy, adjuvant radiotherapy. Radiotherapy is sometimes useful in relieving a localized area of obstruction, particularly in the region of the cardia, and for patients with chronically bleeding cancer that cannot be resected. Chemotherapy, the anti-metabolite 5-tolerated has been used most frequently. Now, most effective and safe medicamental form of 5-tolerated is xeroda, capecitabine. Other combinations include 5-tiocetyl adenomycin and mitomycin. The 5-year survival rate for curative surgical resection ranges from 30 to 65% for patients with stage 2 disease, from 10 to 35% for patients with stage 3 disease. And thank you very much. See you in our department.